Thank you for joining PCR Planet. Today, April 14, will hit the North American continent, and I'd like to welcome Dr. Nicolo Piazza from McGill in Montreal, Canada, and Dr. Azeem Latib from Montefiore Hospital in New York, USA. Thank you for joining and sharing your experience with us. I'll turn to Nico first. Nico, you have had the time with your team to prepare yourself for treating patients with COVID. In a few words, what have been the challenges in your experience?
Thank you, William. Probably one of the more challenging situations has been the fact that we've taken our coronary care unit and we've transferred down into our pre and post cath lab in order to convert the coronary care unit into a COVID floor. And so we are now working in more confined spaces. And at some point, it does get a little bit uncomfortable with respect to the fear of infection and spread working in a rather closed environment. Thank you.
And I'm turning to Azeem. Azeem, you've been working in Italy. You have still many contacts with the colleagues and friends back in Italy. So you knew exactly what might happen. I wanted to ask you, were you surprised when actually the wave did hit you in the hospital, or was everything as you expected?
Thank you, William. We were very surprised. We knew what was happening in Italy, what had happened in Wuhan, and we started preparing for the epidemic. But as you know, I came from a very socialist country with a national health service to New York and the US, where it's very privatized and a private health system. And initially, one of the challenges was that every hospital was working independently. There was no coordinated effort. One of the big changes happened was that Governor Cuomo declared a state of emergency, and he basically nationalized the health system in New York State. And so every hospital, every doctor now works for the state and for Governor Cuomo, and that allowed for a very coordinated response now to the crisis. So he could move around physicians, beds, patients as needed, so that every single patient who needs to be admitted or needs an ICU bed can get one, irrespective of whether they have insurance or not.
Oh, that's good to hear. We sometimes think from Europe we hear about so many patients who don't have insurance. So it's reassuring to hear that actually every patient who needs treatment in your environment will have access to care.
Absolutely. I think this has only been possible because of strong leadership. And really that's been, we have this amazing governor who every day he does a broadcast where he updates the city, the citizens on what's happening, what are the numbers, what he's doing. He's created temporary hospitals so to deal with some of the surge and the overflow. But more than anything, he literally has a meeting almost daily with all the CEOs of every hospital, and he tells them what they need, what needs to be done. So we have this now very coordinated, I dare say almost national system just here in New York State in order to be able to manage the peak. Because remember, we are now hitting our apex this week. We're hitting the highest numbers this week in New York State. And so it did require a very coordinated response into deciding where to send extra ventilators, where to send extra physicians who've volunteered to come and help us.
That's interesting. And, people sometimes say that after the crisis, something good will come out of it. And maybe, this different way of organizing care will be an inspiration for the future. Who knows? Yeah. So, Nico, on your side, you have quite a number of patients, but you've not been overflown by COVID plus patients. So are you still able to treat quote unquote elective cases? How do you select the patients that can still be treated on a planned basis, so to speak?
Yeah, so we've basically canceled many of our elective PCIs we've canceled the elective TAVIs. Our cath lab is working mostly on semi-urgent and urgent cases. And one of the, of course, biggest challenges for us is how do we select which are the low risk and which are the high risk and STEMIs, for instance. And so, we've played around with the risk scores in the last few days, so to speak. And, we've had some patients who had low risk scores, but we decided to cath for some particular reason and had, a proximal LAD lesion. You have other patients who have high risk scores and had clean coronaries. And so, the question becomes, who exactly do we decide to cath? And hopefully we don't miss any important patients who would be helped by a catheterization.
Do you still have a TAVI program ongoing, or is it on hold?
The TAVI program is currently on hold, but we are making telephone calls at home and speaking to patients and trying to understand what patients might need to come in earlier for a valve replacement.
Thank you. Azeem, let me ask you, we understand from colleagues that when patients get very sick, the disease is really nasty. What is it that is maybe unique or remarkably nasty that you've seen in terms of, complicated cases to deal with?
Yeah, like I mentioned, 1 in 4 patients in our institutions right now in an ICU. So we have a lot of ventilated patients that we're looking after. And we knew that they would have severe pneumonias that would require probably 2 to 3 weeks of ventilation. What we were not prepared for was the high incidence of acute kidney injury and the requirement for dialysis. So we started running out of dialysis machines for our COVID patients. We had to start instituting peritoneal dialysis with placing the actual peritoneal catheter at the bedside rather than taking patients to an OR, and using peritoneal dialysis in order to be able to dialyze the large number of patients with acute renal failure.
So you basically, have changed your practice from, very advanced intervention to, I would not even say general cardiology, but more like intensive care physician, right? That is, you have to relearn all of that.
Yeah. So the one thing I would say as a message to our interventional colleagues is that even if in like my center, we overrun with COVID where we've stopped all elective procedures, I want to remind interventional cardiologists that we have a lot of skills as intensivists. We know how to put lines in, we know how to look after sick patients. So what we did was we repurposed our staff. We started a rotation where we sent off interventional cardiologists every day to round in the ICUs to relearn how to manage ventilators and look after ventilated patients. All of us did online courses on the critical care medicine website on how to look after ARDS patients. And so now we are managing our own COVID ICU unit as interventional cardiologists, just because there are not enough critical care doctors to look after, close to 500 patients on ventilators.
Amazing. But as you said, you have reached a peak, and hopefully, the number of the patient load will start to go down progressively. Well, thank you very much for sharing that experience. Is there a strong message or something really important that you would like to share with the community at this point?
Yeah, I would. I think, one of the things that struck me in this epidemic was how contagious COVID is. In my institution, there are over 600 healthcare workers right now who are COVID positive and who have had to stop working and be self-quarantined and isolated, including a number of physicians who have been in ICU and even who have passed away during this COVID epidemic. So my message really to our colleagues out there is, we all did this profession because we had a calling. And in this time, we all needed to help with patients. But my message would be to please protect yourself. This is a very contagious virus. So stay safe, use appropriate personal protection equipment, and look after yourselves.
That's a very important message indeed. And Nicolo, would you like to share some thoughts with before we close this conversation?
I just want to reiterate what Azeem says, because personal protective equipment is really an important feature of what we're doing nowadays in this COVID situation. And it's very important that every patient who comes into our cath lab is considered potentially COVID positive until he or she has a swab and confirms negativity.
Thank you so much to both of you for these, very thoughtful and moving comments. Thank you very much for joining, and keep well. Take very good care of yourselves, and above all, we'll stay in touch and we'll see each other soon. Thank you again. Thanks for listening.
Thank you, William.
Thank you, William.